many patients describe feelings of difficulty with concentrating, feeling mentally foggy, difficulty with carrying out tasks um, with vestibular disorders. And it kind of falls under this broad umbrella term called brain fog. Um, we first tried to figure out how common was this among some vestibular disorders, because so many of my patients tell me about brain fog. So we did a study a number of years ago. We looked at a large US database that's nationally representative. It had 32,000 subjects in it. And what we looked at is self reported cognitive dysfunction. So it wasn't that we gave them a task or something, they just had to answer the question: do you have some difficulty thinking or remembering, or a lot of difficulty thinking or remembering? And if you look at the general population, it's about 2% of people will say they have a lot of difficulty thinking or remembering, and about 12.5% will say that they have some level of difficulty thinking or remembering. So we're not all perfect, but those are the kind of the metric of what we should compare to. We looked at one of my research interests has always been vestibular migraine. It's probably the most common vestibular disorder. So we looked at that population, and we found that it was about 50% in total had some level of self-reported cognitive dysfunction, 40% in the some difficulty thinking or remembering, and almost 12% in the a lot of difficulty thinking or remembering category. So with vestibular migraine, um, and I think it's illustrative of other vestibular disorders as well, the rates of this brain fog phenomenon skyrocket compared to the general population. And what's interesting in that study is we also looked at people who get migraine headaches who don't get vestibular migraine, and they were intermediate. So they had higher levels than control subjects, but not as high as those who had vestibular migraine. So to me, it suggests that it's not really just the migraine mechanism, but it's something about the vestibular system and thinking that is deeply connected. Um, so clearly, this is a huge issue. When we break it down in terms of cognition and thinking, there's different ways to divide it all up. And we talk about, spatial thinking, non-spatial thinking. People will talk about attention, short-term memory, long-term memory, facial and object recognition, language. I think it's important to kind of start with what we know when we start thinking about how does the vestibular system cause brain fog. So what we know is that the vestibular system, if you look at the neuroanatomy, meaning how it's connected to different parts of the brain, you would be most concerned about one type of thinking, which is spatial thinking. And the reason you would be most concerned about that is that we have special parts of our brain where we have an internal compass and an internal GPS system. And those are called head direction cells. That's basically the brain's compass. So certain cells will fire when you're facing certain directions. And then we have place cells, so meaning there's certain cells that fire when you're in a certain place. So it's basically your brain has a Google Maps and it tells you where you are and it tells you what direction you're facing. And those are really important for your ability to navigate spatially. And it's now known that vestibular input is necessary for the functioning of those systems, right? So without a vestibular system, those systems simply do not work. Um, so when we start looking at animal data, we have a strong confirmation of that. So there's a researcher in New Zealand called Paul Smith. I follow all his work, and he's done this fascinating experiments with different animals, including mice. Well, he'll remove their vestibular system and look at their ability to think spatially. And for mice, thinking spatially basically means you put them in some sort of a maze and you see, can they form a mental map of the world around them? And do they understand the space around them? And what we find is that they simply cannot. They cannot remember where the food is. They can't remember where home is. They can still move, but without a vestibular system, they can't form a mental map of the world around them. And that's been shown in humans as well. So humans with bilateral vestibular loss perform poorly on virtual mazes because it's hard to put a human in an actual human-sized maze. None of us have the budget for that, unfortunately. So we just use virtual mazes, and people do pretty poorly. And so we're interested in that, and I'm currently doing an experiment where we're looking at vestibular migraine in a virtual maze, and we're seeing how people perform with this task of spatial navigation. So I would say, and I know that's a long-winded answer, but I would say when we start thinking about how the brain is affecting cognition, it seems like there might be some direct effects in terms of this spatial thinking, and spatial thinking might be more important than we realize. But then there also might be some indirect effects, because when you test people on tasks of attention, memory, things like that, some researchers find deficits in patients with vestibular disorders compared to healthy controls, and some don't. And there's probably some element of dual tasking, meaning you can imagine if you have a vestibular disorder and you're dizzy all the time, a lot of your brain is thinking about that. You need increased neural architecture devoted to thinking about, well, how do I just safely get to the door? Well, then your attention's going to go down, your memory's going to go down. Our brains are somewhat similar to computers. We only have a certain amount of available bandwidth to handle any task, and that can go down as well. I do think that spatial navigation is a fascinating area. I put a chapter in this in my book that's coming out, where I try to discuss the idea of is spatial navigation part of how we form abstract thought, right? So what do I mean by that? I mean, spatial navigation is clearly important for, can I, get to my neighbor's house without using a map, right? But when we talk about ideas in general, a lot of times we talk about them in this sort of mental space that we create, right? So I'll tell someone, oh, I think you're way off base, right? What do I mean by that? I mean, your idea is very far from my idea. Well, why am I using the term far, right? So I think it comes down to, we may be using some of the same neural architecture for abstract thought and for thinking about ideas and how they're connected as we do for thinking about the space around us. And that might be why people have such a global brain fog when it comes to vestibular disorders. How do vestibular disorders interfere with memory and attention in life? So, a few years ago, I collaborated with Dr. Habib Rizek, who's a vestibular guru at the Medical University of South Carolina, at a project looking at what's called the Cognitive Failures Questionnaire, or CFQ, in different vestibular disorders. And the CFQ is a questionnaire that looks at everyday cognitive slips. So the idea here is that you how often do you forget someone's name? How often do you forget where you put your keys? How often do you go to a store and forget what you're there to buy? Now, it won't surprise anyone that the average person doesn't perform perfectly on this. We all have cognitive slips. But those people who suffer from vestibular disorders have more cognitive slips. So this is a metric that's been in use since the 1980s. We used it in a number of vestibular disorders to try to characterize how patients are doing, and are there differences across different vestibular disorders. So we looked at vestibular migraine, we looked at Meniere's disease, we looked at patients who had both vestibular migraine and Meniere's disease, because they co-occur pretty frequently. And we looked at BPPV, which is loose crystals or benign paroxysmal positional vertigo. And finally, we looked at persistent postural perceptual dizziness, or 3PD, as it's frequently abbreviated. And we found that the cognitive slips were the worst by a bit in those with persistent postural perceptual dizziness, or 3PD. But those scores were actually fairly similar to the patients who had both vestibular migraine and Meniere's disease. So those two groups scored the highest. And the group that scored the lowest, interestingly, was BPPV. So it could be that there's factors we don't totally understand here. It could be that the more chronic symptoms you have, the more likely you are to have brain fog, because part of the criteria for having 3PD is having symptoms most of the time. Um, BPPV, that's a whole spectrum. Some people have frequent symptoms, but some people just have symptoms once every few months, rolling over in bed, they do an epi and it gets better. So it might not be enough to trigger that threshold where you start seeing the brain fog. So we did see some differences across different vestibular disorders, but I think the take-home message is that everyday cognitive slips are more common in a whole variety of different vestibular disorders. This idea of dual tasking, or it might even be triple tasking at that point, where your brain has an available short-term memory. I remember back when I was an undergrad, I was told that the average human can remember 8 numbers, 8 digits in their short-term memory, plus or minus a couple, but not that much more than that, right? And some people fewer. So if you are thinking about, am I tilting too much? Do I need to balance more? Suddenly, these effortless tasks become very effortful. And a lot of patients will say that. They'll say that I have to concentrate for each step that I'm taking, right? So it's supposed to be something that's subconscious, right? We don't really think about balance most of the time, but suddenly it's brought up, and the natural processes fail, and therefore you have to think about it a lot more, and it makes sense. So the more dual tasking you're doing, it could be that the more brain fog you experience. So that's definitely one of the main theories with the brain fog. I don't think that explains all of it. I do believe that there are these neuroanatomic connections. There's probably specific effects, and there's probably some parts of this puzzle, almost certainly some parts of this puzzle that we don't fully understand. A few years ago, one of my former residents, who's now a vestibular researcher, an excellent vestibular researcher, Divya Chari, wrote a great review article. And for anyone out there who's listening who wants to dive deeper into this topic, I would recommend that, because it really reviews the current state of scientific knowledge on this topic. And it was specifically focused on vestibular disorders and brain fog. Their findings, or I should say our findings, were that the evidence is strongest for spatial thinking. And we divided up spatial thinking into 3 different parts. So that was navigation, spatial memory, meaning like remembering where things are in space, and object rotation. So that's the idea of, you can give someone a task where you show them a picture, and then you have them mentally rotate that. And then you say, after you mentally rotated it, is it this thing or the thing that's a mirror image of it? And you test someone's ability to mentally rotate objects. Those sort of tasks probably show the clearest deficits in those with vestibular disorders. And almost all of these studies have been done in those with vestibular loss. So either unilateral loss, and evidence is even stronger for bilateral loss. So that's probably the best evidence, is defects in spatial thinking in those with bilateral vestibular loss. We don't have as much data for other vestibular disorders, which is part of why I'm interested in studying spatial navigation in those with vestibular migraine, because it's frankly unknown if they have these deficits in spatial thinking that we do see in patients who have just a loss of vestibular function, meaning their vestibular system just doesn't work as the vestibular system's equivalent of being not hearing or not seeing, right? There is, however, evidence of some deficits in non-spatial thinking. I think the evidence there is not as strong, but some studies have shown it, especially with memory, attention, and executive function. Um, and that we don't really know the mechanism. It could be the dual tasking theory, or it could be some other mechanism that causes issues in those cognitive domains. What can people do for brain fog? So we were interested in this question, and specifically, the form of the question was: if you have someone with a cognitive issue and a vestibular disorder, and you treat the vestibular disorder, does the cognitive issue improve? So, you could construct both realities, right? And say, well, maybe it's a permanent injury to your thinking mechanism when you have these issues, and if you remove the vestibular disorder or cure the vestibular disorder, then it stays, it's permanent damage. Or it could be that it's some ongoing issue, and if the vestibular disorder gets better, then the cognitive issues get better also. So we did a study pretty recently looking at that cognitive failures questionnaire, which is a measure of everyday cognitive slips, and we gave it to people who all had vestibular migraine, which is my usual study population, before and after treatment with a variety of treatments. So we included people who were in a randomized trial of getting CGRP medications, but we also included people who were in a non-randomized study where we used mindfulness-based stress reduction to try to treat their vestibular migraine, and then also people who were just in a prospective observational study where we used a variety of traditional migraine medications, tricyclics, calcium channel blockers, things like that, to try to improve their vestibular migraine. And what we found is that in patients whose vestibular disease improved, so those who improved with their vestibular migraine, and we measured that using our patient reported outcome measure for vestibular migraine, which we had developed a number of years ago, called the Vestibular Migraine Patient Assessment Tool and Handicap Inventory, or VEMPathy. And we found that if your VEMPathy scores improved, meaning your vestibular migraine got better, then your cognitive failures questionnaire scores also improved. So it was able to be treated. Interestingly, if your VEMPathy scores didn't get any better, which presumably meant that your vestibular migraine stayed the same, then the cognitive failure scores didn't improve either. So the two were correlated. To me, that gives me a lot of hope because it suggests that the best way to treat brain fog, at least from what I could tell, is to treat the vestibular disorder. So yes, you can consider techniques like cognitive rehabilitation and ways to get at it from other directions. And that's certainly reasonable, especially because we know that unfortunately, not every vestibular disorder responds to treatment. And it's probably, in this study, it was 70% of people with vestibular migraine got significantly better. So for the other 30%, we still need some options. But if at all possible, I think the first line treatment has to be treating the underlying vestibular disorder. I did a study of mindfulness based stress reduction to see if it would work for treating dizziness. Um, and there were several dizziness and vestibular migraine, and there were several rationales for why we wanted to do it. One of them is about a year prior, we had done a study where we asked people with vestibular migraine to rate their triggers. And we formed a whole list of different triggers, and the number one trigger for symptoms was motion, and the number two trigger was stress. Um, and we also had done an assessment of how often do our patients have anxiety. And it was about 40 or 50% of our patients with vestibular migraine also had a diagnosis of generalized anxiety disorder. So it's pretty high. And I actually didn't think that this treatment would work. So I was fairly skeptical. I thought, well, maybe it'll help with some stress or something like that, and it'll be a good thing to do. Um, but I don't see how it would help with someone's dizziness. But it turned out that it did. It dropped their dizziness scores. It dropped how often they were having dizzy days, and it also downgraded their dizziness. So a lot of patients before treatment were rating their dizziness. We had them rate each day as a mild, a moderate, or severe dizzy day, and a lot of patients before the treatment were rating their dizziness as moderate, and after treatment were rating their dizziness as mild. And their empathy scores dropped about 14 points on average. It was an uncontrolled study, so there wasn't a control arm. But we were seeing a beneficial effect in terms of their dizziness. So to me, that supports the idea that when you have someone with vestibular migraine, any trigger is fair game. So regardless of what it is, you can work on someone's allergies, you can work on someone's neck pain, you can work on their poor night's sleep. Whatever trigger you can identify for them, I think it's a reasonable target, especially for something like mindfulness based stress reduction, which seems to have very few side effects. I find that in some ways, the anxiety and depression is the elephant in the room that we don't really want to acknowledge with vestibular disorders. Um, in our series at UCSF, they're probably present in 40 to 50% of the patients I see with various vestibular disorders, which is way higher than you'd expect through population averages. And there's two main ways to understand that. One is that, and they're probably both true in some patients. So, one is that vestibular disorders cause anxiety and depression. So, meaning if you had 100 healthy people, no anxiety or depression, and then you had the ability to give them a vestibular disorder, I'm not sure why you're doing that, but that's what you're doing. A certain percentage of them with no history of anxiety or depression would develop anxiety or depression. And that makes sense. The vestibular system is critical to healthy, normal functioning. And you can imagine, like growing up, I had a fear of heights. Why did I have a fear of heights? Probably because it's an evolutionary response to prevent me from falling off a mountain, right? Well, if you feel like you're going to fall constantly and consider like how big fall risk is, and uh, for kids, maybe not a big issue, but it can be depending on the circumstance. For older adults, it's one of the leading causes of morbidity and mortality. Falls are a huge issue. So preventing falls is critical. And you have the human body part that keeps you from falling all the time, and you start messing with it, you're going to provoke anxiety. And we see that. We see that neuroanatomically with how the vestibular system connects to different brain chemical areas and different areas of the brain responsible for anxious behavior. So I'm certain that that's true. And we hear that all the time, right? So I have a lot of patients who say, I always ask the same questions, do you have anxiety or depression? And they say, well, I didn't before this all started, but now I do. So I'm certain that that's true. The second theory is that anxiety or depression make it more um, likely for you to develop a vestibular disorder. So it's the flip of that. So this one is that let's picture again. We have a bunch of people. We have 200 people, and half of them have anxiety or depression, and half don't. And then something happens to them, say a vestibular neuritis, and they suddenly lose function of their balance system on one side. And you look at them a year later, some of the data looking at people with vestibular neuritis who have persistent symptoms a year later would suggest that you're more likely to have persistent symptoms a year later if you have a history of anxiety. So it could be that that is part of how the brain conceptualizes new information, how it deals with things, and whether or not we have healthy adaptation or or maladaptation over time with different vestibular problems probably relate to how we're wired, right? And how our brain processes new information. So that's the whole model of how 3PD happens, is that it's a central maladaptation to some initial problem. And based on the data, at least my read of the data, that's likely true as well. So my personal belief is that when I ask questions, when I do my initial interview of new patients coming in, I always ask about anxiety, depression, the same way I always ask about a number of other things, right? I always ask about eyesight and whether or not they could feel the ground beneath their feet because I'm worried about falls. I ask about other medical problems because I need to understand them as a person. And then I always ask about anxiety or depression. Um, so because they're important covariates, you have to tread carefully in that area. A lot of people with anxiety or depression are worried that providers are going to hear that you have anxiety or depression, blame every single symptom you've ever had on that, not take any of your complaints seriously, and basically blow you off. On the other hand, if you don't know about it, you can encourage treatment of it, especially if it's not being treated. So I would say that it's important to assess, because my personal experience is that treatment outcomes are better if you address every single problem that can be addressed. So a complete treatment plan would include addressing and treating those things. I find, by the way, the exact same thing for poor quality sleep. If you have poor quality sleep, I find it very hard to treat a vestibular disorder, and I encourage patients to go get treatment for insomnia or obstructive sleep apnea or whatever it is, just to address that covariate. So I think we have to address the elephant in the room to have the best treatment effects. Getting back to cognition, it's well known that depression and maybe anxiety, but especially depression, can change cognition, um, and it can change cognitive scores, and it may be a deep, you know, uh, neuroanatomic process, or it could be a pseudo process, meaning it just changes how people answer questionnaires and how the scores are reflected. So it's an important covariate that has to be assessed whenever you're doing studies of brain fog. We really have to support our patients, and we have to create an environment where they just feel that this person's on my side, and therefore I can tell them what I need to tell them, because their interest is in treating me and getting me better, and not in judging me or getting me out the door as quick as possible or something like that. And that could be tough because they don't know you. Everyone is obviously going to think about what the prior experience was. Early on, I ran a study just looking at how many providers did the average vestibular patient see before coming into our clinic. And then we tried to see, does that change their attitude about how likely they are to get better? And some sad news there, actually. But logical, the more providers you see, the less likely you are to think that the next one's going to help you, right? And that makes a lot of sense. We really have to spend the time, establish these interpersonal relationships, be professional, and try as much as possible, through asking our questions, through spending the time, through caring for our patients, to get the proper relationship, which is one where the physician is on the side of the patient, and is non-judgmentally understanding the patient, and is doing what is possible within current medicine, to try to get the patient better. There aren't enough vestibular providers. There's a lot of people um, who are for historic reasons or care reasons or whatever, are the first or second line or third line person seeing a vestibular patient, and they may not have the training, resources, time, support, whatever it is, to accurately diagnose, or to treat those patients. So I think whatever we can do in the vestibular community to try to promote education and acquisition of skills is really critical. What we don't know totally yet is vestibular dysfunction or hearing or vision loss just a general marker of neuronal decline, overall nervous system health? Or is it a cause and effect thing, meaning you can construct models and say, well, if part of your brain is there for processing visual information, and when you talk to someone, you're using language, you're using thinking, you're remembering. So you're kind of practicing your cognitive efforts when you are hearing, right? And engaging in conversation and things like that. And when you're balancing, you're using that information to navigate, you're using it to get around, things like that. So maybe it's the kind of the disuse that causes the brain to atrophy. No one really knows that. And that's why these studies on intervention are so interesting, because it suggests if it is that, and it's not just a general marker for decline, maybe we could treat that, right? So maybe the hearing equivalent would be treating people with hearing aids or cochlear implants. And then there's that one study I mentioned that's from Franklin at Hopkins, where people at risk for dementia may have done better with hearing aids in terms of staving off their risk. That would suggest that maybe there is some benefit to be had for treatment. And at this point, we have vestibular physical therapy. A whole fascinating area of research will emerge once the vestibular implant, which is being developed and is in human trials, gets more widespread. Then we might have a way to directly restore vestibular function. And then it'll be interesting to see, well, in those patients we talked about earlier with bilateral vestibular loss, can we restore some ability for spatial navigation? And if you treated enough patients and organized a big enough study, and I don't know if there's enough patients out there, could you figure out, can you prevent some of these cognitive issues? To be responsible, we should probably say that most of the data seems to suggest that developing dementia of various types is a multifactorial problem with a lot of different contributions from many different things. And when we talk about risks, we're talking about very small absolute risks. Um, so we don't want people to worry that, oh, my hearing got worse, I'm pretty likely to develop dementia. That's not the case. But from a medicine standpoint and a population standpoint, especially, I think it does behoove us to ask these questions. We are faced with an aging population, and we need ways to deal with dementia. Dementia is a huge issue that we all have to worry about, and it's a huge source of healthcare costs, and loss of independence and all these bad things. And it's kind of a sad way to exit life in some sense. So any sort of target for trying to treat that, I think makes a lot of sense, because a lot of the things like your genetics or how long you've lived are not modifiable. But if you could put someone into physical therapy, or you could give them a hearing aid or some sort of visual aid, and if that turns out to be helpful, that's very intriguing. So I think at this point, more research is needed to sort these things out. But it's very clear that we ought to be exploring any possible treatment avenue for dementia.